use the mic. The mic is not working. So,
should we move on? Why not?
I'm much louder than she is, so this when the talk is going on, it won't be as much of an issue.
As you know, the bios of our speakers are in the program, but I did want to say, as somebody who works on gender and sexual reproductive health, how unusual and refreshing it is to meet a man who is an expert on midwifery and birthing in the United States, and I'm very much looking forward to this presentation, and I know that you are too.
Just to pick up on the point that Margaret was making about it's unusual for a man to be in this, a great benefit, and the reason I continue to do it is that when you go to all the conferences, you're the only guy in the room with 1,000 women, and that's a pretty neat deal for folks. I wonder how often I'm going to go off the edge.
Perfect.
People see that well enough? Great. It's not that big a room. So I'm going to talk about a lot of things. I did research a number of years ago on immigrant, and I talk this fast all the time, okay, on the immigrant midwives of Lawrence, and Susan and the organizers asked to incorporate some contemporary material in as well, so I have. So it's actually in several sections. And just always note this, that the work I'm talking about isn't just me, it's a whole bunch of collaborators. And these are all people I've published with over the years, which is a reflection of a couple things. I'm very old, so I've worked with a lot of different people over time. And I'll note that people who are in yellow are all midwives. And so I've worked with and researched with a lot of midwives over the years. But I should also mention there's about 15 OBs, obstetricians on that list as well, and I'm on an obstetrics faculty. So a big theme of my work is collaboration and the need for different sectors within medicine to try to collaborate. So there's a lot of data in this, and having come from a session with very powerful poetry, I got no poetry here. Okay? I got numbers. I got more numbers than you could ever imagine, but hopefully they'll make sense. I will, this website, I'll put it up again, I post all my stuff on that, and so if people are interested in the slides afterwards, I'm going to be posting them at that birthbythenumbers.org. I'll recognize Christina Gebel, who's one of the students I had before, who was one of the people who started the website with me. So actually, this is a standard slide I use. You can probably take pictures of the data slides. I did this research some time ago. You always worry when you're doing presentations if people take pictures of slides on research you haven't published yet, but you want to convey to an audience. And so that's just a standard caution. So this is the breakdown of it. I'm going to talk about the two periods, 1890 and 1920, which was the period of the greatest agitation against midwives in the United States, and 1990 to the present. And if you're good, there's even some bonus material that goes beyond that. That's up to you. Depends on your behavior in this session. We're going to talk about maternal infant health status in the U.S. and Mass. We'll talk a little bit about it in Lawrence. Then I'm going to focus mostly on this, the campaign against midwives in the U.S. and Massachusetts, and then the actual events in Lawrence around that campaign and what the significance was. And then a little bit on the return of midwifery in the United States. And I pulled together as much data as I could on the current maternal and health infant status in Lawrence as well. So, where were we back then? 1890 to 1920. And I'm already lying because my first slide, this is from 1665. This was just lists of diseases and causes of death in London. It's one of the first times people started to try to classify why people died. And I wanted to give people a sense of the evolution of this process. And you can see some of the things that are pretty familiar. Consumption, plague, but you also have things like spotted fever and purples, rising of the lights, French pox. That's syphilis, because that had to come from the French. We know that, right? Grief, I find that powerful in itself. I like this, killed by several accidents. That's a bad day. A really bad day. So that's one thing, several accidents. Quincy hanged and made away themselves. A remarkable individual to have been both hanged and made away all by themselves. You can look all these up, by the way. They're all terms that are now used for different, this term here, where was it? Sorry. No, I'm sorry, it was above here. Consumption and Tissic. That was initially the wonderful term Phthisis, P-H-T-H-S-I, which became consumption, which became tuberculosis over time. So there's an evolution in the history of health of trying to get a better sense of what are we talking about with disease? How do we classify this? How do we talk about it in a way that when I say something here, Margaret 1,000 miles away knows we're talking about the same thing? That's stage one in all of this. So this is the crude death rate per 100,000 for infectious disease. You've seen things like this already today, so I'm not going to belabor it. And I certainly wasn't going to talk about the flu pandemic since there's been 37 actual talks today in the flu pandemic. But you can see this jump. But the larger point in all of this is the movement from infectious disease to chronic disease as an issue. The decline in the impact of infectious disease, and that's one of the great successes. In the context of maternal and child health, you see this with infant mortality in the United States over time. A dramatic decline, although notice the decline decreases, and that's not just because we're getting so low we can't decrease anymore. It's slowing down in the United States. Oops. And, there we go. And this is maternal mortality. And that presents a much more positive picture than you could imagine. We'll maybe we'll have time to talk a little bit about maternal mortality in the end. Because maternal mortality in the United States is actually rising at the moment. And that's a worrisome trend. This is Massachusetts. One of the nice things about being in Massachusetts is we have better data than most other places. We're better at everything than most other places. And one of them is we started recording things earlier more systematically, more thoroughly than other parts of the country. This is our focus. And this period of about 1890 to 1920, you can see a dramatic decline. Again, here's the pandemic, but a dramatic decline in infectious disease, and you start to see the rise of the more chronic diseases as being a serious element in all of this. And by the way, note this piece, injuries, sort of meandering around, but starting to increase again. This is simply looking at deaths in Massachusetts by age. It's the kind of thing we high-level researchers do to prove something like people live longer than they did in the past. But this is the part that's really interesting for the discussion here. Right? That this is the proportion of all deaths that were occurring less than 1 year old out of all of the deaths. And that's a relatively insignificant proportion of all deaths now. Most people die at much older ages, thank God. But at that time, this was the most serious piece of it. Now, one of the things that we have to wrestle with is, so they start documenting deaths. Deaths are straightforward enough to document, right? Died, didn't die, pretty easy classification. You kind of all agree on it, although it becomes more complex than you think. But the question started to become, how do we know one community is doing better than another community? If one community has more deaths, are they doing better or worse? And your immediate response is, well, Boston has 10 times the number of people that Lawrence had. So what do? This is the start of the development of vital statistics. And the idea of trying to figure out how do we compare? How can we compare things? And this is the Massachusetts infant mortality rate. Starting in 1915, they systematically recorded. You can see it's a rate per 1,000 live births. And the rate back then is 100, around 100. In other words, 1 in 10 kids did not make it to the first year in life. Infant mortality goes out to 1 year. And 10% of the kids are not living through that first year. But the building up of vital statistics leads to this. The need to have some, what we would term a denominator. If you're going to count deaths, you have to count something under that to do the comparison. And so you have, and you're saying, boy, is this guy giving us a lecture? Yes, I am. But this is what leads to the study that I'm going to talk about today. Because the birth certificate movement started not on some theoretical grounds, But it started on the basis of trying to get a denominator to put under all of those deaths so they could compare one community to another. And so in the late 1890s, communities start to have birth certificates. In Lawrence, in the basement of the Lawrence City Hall, they have the old birth records, literally little sheets like this. Well, not this big. It would be a kind of remarkable thing if they were all this big. But sort of this by this. And they record a number of bits of information in all of this. This was a birth in October of 1914 in Lawrence. And there's actually a remarkable amount of information on this, if you think about it. There's ages. This is the actual birth certificate. I'll talk about this later. This is the actual birth certificate. Get the date, get the gender. They have names. I've covered the names. You have the place of the birth, because typically it's going to be at home at that time. The first recorded birth in Lawrence General Hospital doesn't happen until 1903. And there's not 100 births at Lawrence General until 1915. So births were happening at home back then. Age of the father, residence of the parents, occupation of the father, occupation of the mother. It wasn't until 1911 or 12 that they started adding occupation of the mother. They would only have occupation of the father. Birthplace of father and mother, and who attended the birth. All of this is there available to use. They were doing it primarily in order to simply get numbers in all of this. If you were to look at the back of it, the back of the sheet simply has a statement that says, those who attended the birth will either have to turn it in. If they turn it in, they get paid 25 cents. If they don't turn it in, they get fined $10. And so that was the way to try to generate this. And $10 back then was what a mill worker would make in a week. The U.S. wasn't the only country that was establishing this birth certificates at the time. This is my father's birth certificate from France at the time. And it has a lot of the same information that we were talking about in the other context as well. So this is an international movement that's going on at the time. And so this allows us to get infant mortality rates and get a systematic way to measure it. And again, it's deaths up to 1 year of life times 1,000 over births. And you can see, as I said, back then it was around 100 per 1,000. You see this gradual decline through this entire period of time, to the point where now the United States is at around 5.8, 6 per 1,000, which sounds pretty good, except that most European countries are about 3 or 4 per 1,000. And so we're behind virtually all the other industrialized countries. This is Massachusetts. This goes further back than the previous slide. This goes back all the way to 1842, so I'm not quite sure how well they did that because they didn't have those things. But who are we to question the state of Massachusetts Department of Public Health? And so these are the records, and some of this inconsistency you see is probably simply record keeping at the time. But again, the same kind of general decline. And this is the Massachusetts, again in red, U.S. in blue. And you can see for the most part, Massachusetts does a little bit better than the country, which people in Massachusetts make a big deal about. But that's a pretty consistent pattern through this time period. All of this is coming through because it's starting to have a self-consciousness about this, that we need to do this. This is an important element in public health that stems from the work of a lot of different people that started to say we need to know how well we're doing. And that goes to people like Florence Nightingale, of all people, who aside from being a pretty aggressive nurse, was also a remarkable person in terms of pulling together data and presenting data in really innovative ways 100 years ago. Where's Lawrence in all of this? This is the Lawrence mortality rate over time. And this comes from when we developed the exhibit. My wife and I worked on developing the exhibit that was presented at the Heritage State Park 15 years ago, the one that Howard Coe had introduced. And we went through as many of the records as we could, along with many other people at the time. But it's kind of interesting. This is overall deaths. But you note some keys. At a community level, it's going to be much more inconsistent, right? Some of this is record keeping, but you see that that's the kind of thing where the Pemberton Mill disaster can actually have an impact on a community's death rate. It wouldn't have an impact on the state death rate, but at the local level at night. This is, in Lawrence, the highest infant mortality rate that the city had ever reported was in 1876. It was 33%. 1 in 3 kids wasn't making it out to a year in Lawrence in 1876. Then you see the same pattern, for those of you who are at Passtock, the same pattern. When they start cleaning up the water, the deaths start to drop for all reasons. It's not just infectious disease deaths, but all deaths begin to decline through that period of time. Then you have issues like cholera and phantom, which I'll talk about in a minute, because who doesn't like to talk about cholera and phantom? And so I will as well. And you can see individual pieces here as it starts to decline. And then later we start to have the same pattern we see in the overall figures, which is infectious disease declines and chronic disease, heart disease, cancer starts to become a bigger issue, partly because people live longer. And as a result, they get to the point where when we said there was low rates of cancer, it's because everybody was dying before they could get to that point. Okay, oops. And this has nothing to do with my talk, it's just so cool. That this is an effort that was underway back then to document disease in the city. This was diphtheria, mostly affected kids. And it's hard to discern on this, but they have solid circles and open circles. And the solid circles are households where a case of diphtheria caused death, and the open circles are simply a case of diphtheria. Think about the human power. It would have been manpower back then, actually, but necessary to do. Literally, you had to go house to house. They did surveys, house to house, to see if there was a death in the previous year for this disease. Diphtheria is a huge issue back then. So you've got this whole effort to try to get a better handle on things. I mentioned cholera and phantom. It was one of the most profound. In that 20-year period, about 100 kids a year died from this. And this is the description of it. And it was very much a seasonal disease. It just took off in the summer. You see that as well here. This is all non-infant disease deaths. These are other infant disease deaths, and the red reflects the cholera and phantom and the impact it had. Note the impact it has in the summer on the overall death rate in the community. And then this is infant mortality rates in Lawrence and the state over this entire period of time. And the red's Lawrence, again, it's more inconsistent than the state would be because it's smaller numbers. Pretty much from 1850s up till the 1920s, significantly higher than the state as a whole. But then from that point on, Lawrence is still higher. You'll see that at the very end of the talk. But not in as profound a level as it once was. All right, let's turn to, that's the context for all this. We're in a period of turmoil. There's a lot of concern about infant death in particular. By the way, not nearly as much concern about maternal death. And the history of maternal and infant health is the focus on maternal health only to the extent that it can produce healthier babies, which is the thrust of a lot of my work right now. So part of all of this is a campaign against midwifery, nationally, but particularly in Massachusetts. This is sort of a classic example of midwifery. The only useful thing that the father can do is hold her, while the women do all the rest of the actual work in this case. But this is a famous picture as well, because this is the one that's done to attack what they term man midwifery. Man midwifery was the development of obstetrics. And there is no such thing as obstetrics back in the 1800s. Right? To the extent that doctors are involved, they're general physicians, family doctors, who are doing this. And in the late 1800s and the early 1900s, again, you have this sort of sense of profession that develops around obstetrics. And one of the pushbacks on this were these kinds of things. What are men doing in this? This is a portrayal of the unfortunately named William Smellie, who was one of the first man midwives out there, and trying to establish this profession of obstetrics. Now, the problem with establishing a profession of obstetrics is there's all these damn women who are delivering babies, doing it pretty well, and so how do we pull people away from them? And that becomes the crux of a lot of this campaign. This does not start in the 1890s. This goes all the way back here. This is Remarks on the Employment of Females in Midwifery by John Weir. It's 1820. It's out of Boston. The circumstances which would render females agreeable and most desirable as attendants in childbirth are obvious to everyone. But the objections to their employment are of a nature not so immediately perceived. except by physicians. And so you start to get the sense of where we're going with all of this. This is another one of his comments. Women are distinguished for their passive fortitude and firmness to a much greater degree than men. And this, whether they are called on to endure suffering themselves or witness it in others. They have not the power of action or the active power of mind, which is essential to the practice of the surgeon. And so you start to see the early renderings of childbirth as around surgery. Does surgery play a role in this? And this is the tension that still exists between midwifery and obstetrics, for the most part, in terms of how one views the process of birth itself. So, some of this is a campaign against midwifery, and a lot of this is that midwives are collateral damage. They're sort of in the way of the development of this other profession. And so three key pieces in all of this. One is hospitals have to be redefined. Because in the 1800s, hospitals were places you didn't go to. If you were wealthy enough, doctors came to you. The premise of that was only the poor would go to hospitals, or the mentally ill would go to hospitals. But the idea of hospitals as centers of learning doesn't happen until much later than this. So that's one piece. Hospitals have to be redefined. Second, birth has to be redefined. If birth is a normal process, then you don't need specialists. If it's a dangerous process that's death moving around every corner, then you do need specialists. And so there's a conscious campaign to redefine birth through this period of time. And the third is you have to start creating some profession that we'll call obstetrics. So articles start to appear in medical journals and the general media attacking alternative practitioners, like irregular doctors and midwives. And this is just one of the publications that sort of gets at all of it. Midwives, chiropodists, and optometrists. Basically, all of them are bad. None of them are us, right? So, this is the first piece, redefining hospitals. There were a number of lying-in hospitals around the world, and they served their special purpose around that, and they were greatly revered in their communities. They happened in the United States as well. You have Chicago lying-in hospital, New York. You have Boston Hospital for Women. Not many good images of Boston Hospital for Women, actually, online, that I could steal for this talk. In addition to elevating hospitals, midwives had to be eliminated, or there wouldn't be enough patients for future obstetricians and physicians to train on. And that becomes a theme in all of this. If the midwives are doing all the births, then how are we going to train anybody to do births? This is the Colville Hospital in Lawrence. It has in Methuen. It has nothing to do with the talk, other than that's where I was born. And I just thought throw it in there along the way so you can see. With the our family physician was the birth attendant. So you've got this whole movement of working with hospitals, and you see this rapid rise in the number of hospital beds in the United States, up to the point where it is about 1,600,000 hospital beds. Now, since then, that becomes inefficient, and the numbers have been going down to the point where there's around roughly 900,000 in the United States, as they try to make them more productive, if you will. That's why when you have that enormous operation and they say a day and a half later, you're ready to go back. That's to keep things moving. Another thing that helps hospitals in all of this is scientific developments. Because, again, if they're bastions of science, then you can get people to come into them. If they're the places that the poor people go, then no one's going to want to go to the hospital. And so the redefining includes this, and twilight sleep was a big part of it. Twilight sleep was a combination of what was called scopolamine and usually morphine. Later it became combined with other things, Demerol and some other things. And what it did was it didn't knock a woman out, because initially it was ether and chloroform that we used. Those would knock women out, but they had profound effects on the baby. So they were trying to look for some other alternative. The other downside of ether and chloroform is they could be administered at home pretty easily. Twilight sleep had to be administered in a hospital. And so you have this whole twilight sleep movement that starts around 1910. It's discovered in 1909 in Europe, in Germany. Doesn't take off in Germany or Europe nearly as much as it took off in the United States. And it has two really interesting things. One, you can only get it in the hospital, so it's a great impetus to bring women in the hospital. So the argument is, you see the sleeping part, twilight, motherhood without pain. And you also have the development of actual twilight sleep hospitals in the United States. The other thing that's really interesting about this is this becomes a woman's movement. remember, this is the early 1900s when the suffragette movement is really rolling, right? We have suffrage come in the late teens. And it becomes a cause for upper income white women, essentially, to say, we can be free from the problems of childbirth. Science will free us from all of that. Now, the effect of this, by the way, scopolamine is it's not a pain reliever, it's an amnesiac. And so it gets you really great ethical question of, if you don't remember a pain, did you experience it? Chew on that.
And women acted very strangely.
Very strangely, yeah. And that, so the famous thing when people in the 50s, 60s, 70s would see straps on the beds, they would wonder why. That was because women on scopolamine would reach down and would flail around because they were basically out of control. They didn't remember much of that. They might have some vague negative feeling about that later, and we don't have time to get into it, but that's sort of where the natural childbirth movement comes in the 60s, as a response to that. I'll just make one other quick note. See, this is the Twilight Street Maternity Hospital. It's actually at a 197 Bay State. That's now a BU administrative building. So whenever a strange decision comes out of central administration at the school, I kind of assume the lingering Twilight Street. And again, now we have the redefinition of birth. Recent meeting of the American Gynecological Society, and this is Joseph B. DeLee, who's a major figure in the history of obstetrics. The papers read were deeply interesting, but they presented the dangers attending ordinary labor as being so numerous and so fearful that a person unacquainted with the process would have reasonably assumed, reasonably supposed that but few women could pass through it unharmed. And that becomes the theme. Because if birth is incredibly dangerous now, then we have to bring it into the hospital, and we have to have specialists take care of it. So all of this is a theme. Now, you have the establishment of this profession. You have the first meetings of people calling themselves obstetricians. The society started to form. And it's really important to keep this in mind when we talk about midwives, because midwifery societies never formed. There's almost no common sense of a profession among the midwives that we're going to talk about. Whereas there is in the case of the physicians. So, two of the things that come up. One, why? Because they're women, they can't even be trained to do this well, is one of the themes. And the other is that midwives are the abortionists. Laws are poorly enforced. The man who expectorates on the sidewalk is far more likely to find himself amenable to the law than the professional criminal abortionist. So the charge that midwives were abortionists was another piece of this campaign. Because it was true. Midwives were more likely to have performed abortions at that time. One of the midwives that I'm going to talk about that was one of the Lawrence midwives, it was really hot. I mean, I was talking about people who had died decades before I was doing the research, but I was tracing their relatives, and I talked to some older people who knew, and I mentioned one of the names, and the first thing the person said was, oh, the abortionist. And so, there's some of that is true. It's so pleasant, this. And then, redefining midwifery in the public's mind, tons of articles, mostly written by now the nascent obstetrics, obstetricians, for popular magazines. And you even get help from Charles Dickens, of all people. He and actually, Pat noted this today, Martin Chuzzlewit has Sarah Gamp as this slovenly, drunken midwife. And that becomes an image that gets used a lot. She's all over the place. I'm not going to read the quote, but that's sort of the classic bad midwife. By the way, there were bad midwives. There was some of that was true, but generally not the case at all. All right, so what happens in Massachusetts? There's a few things. These aren't all about midwifery, but they ultimately have an impact on midwifery. There's the Birth Registration Act. That's the thing with the birth certificates. Again, I doubt if you went through all of the discussions around the passage of that, anyone would have said this has anything to do with midwifery. Right? That was trying to do vital statistics. This did have much more to do with them. In 1894, they passed the Medical Practice Act. And this is what establishes what medical practice is. It establishes a board of registration in medicine in Massachusetts. It establishes the rules by which one could be considered a doctor in Massachusetts, which, by the way, had two criteria. The passage of an exam that was approved by the Board of Registration in Medicine, or graduation from Harvard Medical School. Really, that sends the sense of the prestige. But think about these two things together. Because if this says only doctors can practice medicine, and this says you have to register every birth, a midwife attending births by signing that birth certificate is in essence putting herself in conflict with this law. And so that becomes the crux of the court case I'm going to talk about in a moment. Our next step in all of this is, once you've established they're practicing illegally, you have to go after them, right? You have to prosecute them. And so you start to see the prosecutions, and I'm going to talk about one of them in the case of Hannah Porn. And then the final piece to sort of close all this out, you have to go after the people who were supporting them. If they work with a doctor, you have to go after the doctor who might have been helping them. Right? And so you can see this evolution through this period of time. Again, roughly 1890, probably 1920. So I did a whole series of articles. What's really, you can see the dates of the articles. What's remarkable is I was only 7 years old at the time I wrote these articles. And so I just got off on this. It took a long time, and there's a lot of research. It's really cool. Partly it came, Richard LaQuarrie was a student of mine. I was teaching in Merrimack at the time. And he said, do you have any, and I always have a list of projects. And if any of you are interested, I still have a list if you want to work with me. And I said, why don't we look at these midwives in Lawrence, see what we can find. And it took like a year and a half to get into the Lawrence, to get Joe Smith, the Lawrence city clerk, way back then. Very patrician old guy. No, you can't look at the records, can't look at the records, because it's entirely up to the discretion of the clerk as to whether or not you can get access to those records. And I kept going back to him, kept going back to him. And finally he said, yes, you can look at the records. And we did, and then 30,000 records later, we have all this stuff. So, legal sanctions. This is the case of Hannah Porn. She's a midwife who became the center of a court case back then. She was charged with breaking the law. And she's a bit of a hoot, and I'll talk about her for a bit. But that becomes a key element in this. I'm sorry, I'm so bad at this. And so this was the crux of this, and I love this quote. When she's in the final court case that she has, she says, the reason I continued the business after being told by the court to stop the work is that I thought the law is unjust. I never worked only among my own people. She worked in a Swedish-Finnish community. Not a huge community, sure. But it is out in Gardner, Massachusetts, where she was. And she was from Sweden, the Finnish part of Sweden, apparently. And only worked, if you look at the birth records, virtually only among Swedish Finns. I'm sorry, she was from Finland. She was born in Finland in 1860, comes after her husband dies. She comes to the United States to meet up with her brothers, who were part of the whole furniture creation thing in Gardner, Massachusetts, still a big furniture place, I believe. They were making baby carriages. She goes to school, graduates with a degree in midwifery from the Chicago Midwifery Institute in 1896, comes back. Between 1896 and 1908, attends about 650 births, second most active birth attendant in Gardner at that time. She works almost exclusively in the Finnish community, mostly to people whose professions is listed as chair makers and laborers. She charged $2 to $5 for her services, although she had an office, which most midwives didn't have. Signed, Hannah Porn midwife. She has, all this shows is her outcomes were as good as the physicians, and she wasn't like dealing with a low-risk clientele. She was dealing with laborers and mill workers for the most part. Very good outcomes, as good or better than the physicians at the time. This is the key. You start to see she is doing this, but she's eating up a big chunk of the total births in the city. And once she's finally gone, the doctors take over. So some of this is interprofessional bribery that we're talking about. Because there were no complaints that were brought by her patients. The complaints were entirely brought by other obstetricians, family physicians for the most part at that time in the community. So, first case, July 27, 1905, she makes the mistake. The old line you've always heard about, ask for forgiveness, don't ask for permission. She asked for permission. She wrote to the Board of Registration in Medicine in May of 1905. There's nothing specific in the Board of Registration minutes, but I found in one of them, shortly after this period, it's a 3-hour meeting, and it says, long discussion of the midwife problem. Shortly thereafter, she's prosecuted, brought in charged with violating the Medical Practice Act. She loses the case, she gets a $200 fine. The Medical Registration Act said you couldn't practice medicine without being approved by the Board of Registration in Medicine. She appeals it all the way to the Mass Supreme Court. Her basis of her claim is this: she doesn't practice obstetrics, because obstetrics is one of the things that's listed in the Board of Registration of Medicine as constituting medicine. I don't practice obstetrics, I practice midwifery. And she meant it. We'll see that in a moment. The court says it would be possible for the legislature to separate by a line of statutory demarcation the work of a midwife from that of a practitioner of medicine. However, that's not their interest. Their interest was in the maintenance of a high standard of professional qualification for physicians. In other words, they said the state legislature could do this if they wanted. They could establish a separate line. This is at a time period, by the way, in England, where they were doing exactly that. They established the Midwives Act in 1902 and defined more clearly what a physician does and what a midwife does. That was not the case in Massachusetts. So she loses the case, and what does she do? She keeps practicing. So she's arrested again, found guilty, fined $250. The fine is dropped because she promises to leave Gardner. She doesn't leave, she keeps practicing. She's a tough old bird. 4 Gardner doctors then bring charges against her and testified in the latest trial. In 1909, finally she's sentenced to 90 days of hard labor for her persistent determination to carry on the work. She's in her late 40s at that point. Again, no charges about bad practice. The only time there's a charge was a case that was difficult. She had called in the doctors because of the difficulty. The doctors wouldn't come into the house because she was there. And finally, she left. They went in, and by then it was too late. In the following year, the 4 doctors who brought the charges against her increased their birth attendance by 63%. I just want to point this out. The point I made about what she said she was. So here's the line that the birth attendant has, and it says physician on it. And she always, in every one of the sheets, she crossed it out and wrote midwife instead to establish what she thought. Here's the quote I cited earlier. Now, after the court case, she still keeps practicing. How do I know that? Because suddenly, well, she could have stopped practicing, and suddenly fathers in the Swedish-Finnish community in Gardner, Massachusetts decided they wanted to attend births where they hadn't before. In other words, the proportion of fathers signing birth certificates in Gardner at that time goes from like a fraction of 1% to about 5%. So work that out on your own, how that might have happened. She died July 8, 1913. Her obituary says she was strong-willed and hard-working, but she was not the friendliest person in the world to keep doing that. What's really intriguing is her obituary said she died while in the practice as a nurse at this particular household. Now, I had gone through all the records. She was never trained as a nurse. So I looked through the birth. I went back and went through the birth records. And there was a baby born at that house that day, the day she died, which is both very dramatic and sort of rounds out the story in a very powerful way. And it's also the worst birth experience for that poor mother. I could ever imagine of having a midwife keel over in the midst of this entire process. Now, what does this mean for Lawrence? Finally, this guy we're going to get to Lawrence. Yep. Down rolling. You said I had till 4 o'clock, right? I get close to it. Lawrence is an immigrant community, right? And it's a home for midwives. What happened was the midwives that come to Lawrence are all from other countries, which is like pretty much everyone from Lawrence, right? I did this research before I did the Hannah Point research. I was curious. The big finding was this. This is the proportion of all births in the city attended by midwives in Lawrence. And what you see is this rapid increase through this period of time. Here's the Hannah Point decision. My assumption had been that it all disappears. But it doesn't. They keep signing the birth records. They're still as active as ever. Why is this a big issue? I suspect it's this part, the decline in physician-attended births through this period. And that becomes a more contentious issue in Lawrence. This is the issue around immigrant midwives. This is just Lawrence was seen as an example of the midwife stronghold, a manufacturing city of about 100,000 population, largely composed of immigrants. There's another quote where a physician says, midwives are only successful among immigrants because they're such prolific breeders. A line we've heard again, right? That's not hardly a new comment. Is this true? Well, yeah, look, this is proportion of births to foreign-born mothers, not just immigrant second generation, but foreign-born mothers. We're talking 80–85% of the births in Lawrence are foreign-born mothers. So they're coming over and they're bringing the customs with them, and they're also bringing the midwives with them, right? Because the midwives themselves are coming over. And in fact, when you start looking through their records, a lot of them were midwives. They were physicians in their country, and they came over and couldn't practice as physicians, and so had to practice as midwives. So this is the growth. I'll just highlight this piece. Total midwife births, you see it goes from about around 300. At the 1896 is the first year you start to get consistent records in Lawrence, and some records prior to that, but this is when it really takes off. And you can see this growth, and it starts to surge up to over 1,000 births a year in Lawrence being attended by midwives. Louisa Beck is the first one who really sort of stands out. Her practice goes literally to Minnie Ream. The day that Louisa Beck has her last delivery, Minnie Ream has the next one. Louisa Beck had an ad in the paper, and the next day Minnie Ream had the same ad. And then Minnie Ream becomes far. By the way, if you know of any of these midwives, you've got some connection to them, please God let me know. These are the midwives. And again, I'm not going to go through all, but you see the diversity and who they serve. And there's two kinds of midwives in Lawrence. The most dominant are the midwives who only work in their own little communities. Literally, right within their own communities. I had somebody who did 6 deliveries at the same address. And some of that's a function of the fact you got four-story places that are all crowded. So some of the midwives, and I'm so old, we didn't have geocoding back then. So I sort of geocoded. I used precincts, city precincts, and there's 36 precincts, and I geocoded all of that to precincts. And you can see some of them work in virtually all of the precincts, and some of them work in just a handful of the precincts, right? And so you can see this diversity of practice. So you've got Hedwig Himma, Minnie Ream, they work all through the city. You know, Hedwig Himma had a car, and she would go around the city. And then you have others who work essentially just in their own little communities. I interviewed one of the descendants of Elena Stella, and a line that's always stuck with me. I said, so she worked in the Italian community? He said, no, she didn't work in the Italian community. I looked at the records. All of them were to Italian mothers. He said, no, she worked in the Sicilian community. So I wanted to get images of these women. I think these pictures are remarkable. None of these are the actual women. These are just women that have the same names. Just so you know, the Google images, you see what you can find. This looked close. I thought I almost had it with this one. But no. You know, part of it is there's not tons of records here, right? These were not elite people who necessarily had a sense of legacy, that they were trying to leave something going forward. I never found any records from them. No diaries, no any of that. I did get one really important lesson for all of you who are aspiring historical researchers who want to use Google Images. Looking up these names is fine. The name you don't want to look up is here. I didn't know they would have that kind of stuff on Google Images. My God, don't do this. So how do the Lawrence midwives survive? A few things. They had good outcomes. I did an analysis of their outcomes. Every bit as good. They would work with some helpful doctors. They had great support in the community. So they keep going up until September of 1914, whereupon they're all arrested. And at that point, they're all brought in, they're arrested, minor fines. But again, they're significant people in their ethnic communities. Their spouses were often leaders in the Italian community or in the, well, not the Irish community. The Irish community relied mostly on doctors. But in the Italian community, the German community, midwives were really dominant figures. So they had a lot of community support. They were more flexible in their payments. They would take payment in kind, which others didn't. They advertised. It was in the newspaper. You can find it in the old Lawrence newspapers. And then they went underground. In the same way, after 1914, after September 1914, you see the surge in father-sign deliveries in Lawrence as well. One last point I'll make. This is kind of cool. So they go out and they do a city canvass. of birth. So they not only just have the birth certificates, as we've seen, but then for a few years they went out and set a city canvasser out to go to every household in the city and ask if a birth had been happened. And they picked up like 100, 150 births that were not on birth certificates at the time. The cool part is this. So this is signed by, the birth certificate is signed by Collateral, right? When they go and they do the canvass and they ask who attended this birth, the family says, oh, that was Virginia. Well, Virginia is Virginia Pedrazini, one of the midwives. Because they don't know about the law. They don't know anything of birth certificates. And so you actually, this is a good sign. Note this is after the period of time when the midwives supposedly have been arrested. So they continue to practice for time after that. Okay, I'm going to wrap up in a quick one. I'm not going to get into that. Midwifery has come back, sort of. They attend about 13% of all births, vaginal births in the United States are attended by midwives now. Massachusetts sort of upper middle of the pack on all of that. This is the distribution. You can see some places that the darker is places with more midwives. You can see that's why there's problems in the South, because they don't rely on midwives nearly enough. And you have pockets of places where they're particularly popular. New England is one of the places where midwives are much more active. And then finally, current status in Lawrence. This is still an immigrant city, you know, where you're talking still 75% or so of the births to mothers of Hispanic origin, but a significant portion are even still foreign born. How are we doing in Lawrence? Okay. I think that's a technical term we use in public health. Not as good as the state of Massachusetts. On the other hand, the state of Massachusetts itself does really, really well. So it's usually in the top 3 or 4 states in the country in terms of its outcomes. So Lawrence, if you compare this to a national, it would be kind of interesting. And I'll make this last point on this. If you look at services broken down by ethnicity, one of the intriguing things on Lawrence outcomes is Lawrence does worse on, take prenatal care, mostly public in Lawrence, right? Adequate prenatal care, we don't do as well as a state. Teen births, higher, although notice how much that's coming down. That's part of a national trend. Birth rates of Hispanics have dropped like a stone in the United States as a whole. And that's been reflected in fewer teen births. And an infant mortality, you can see. But again, Massachusetts has this, like the second best infant mortality in the country. But if you break the data out by ethnicity, what you find is this. Hispanics in general in the state don't do as well as Hispanics in Lawrence do. And part of that is, I think, the concentration of services that are ethnically sensitive in Lawrence and more culturally competent in Lawrence as a whole. So when they say Lawrence doesn't do as well, it's got a higher concentration of people who are at greater risk. But the service delivery in Lawrence is actually pretty good relative to all of that. And I think that balances some of that out. So what does this all mean for maternal and child health? Oh my God. Okay, bye. This last one, just to tick off anybody who might be at Holy Family Hospital. This is cesarean rates in the state as a whole is the green. Lawrence General is in red. And Holy Family, this is primary. This is first time cesarean rates. Their overall cesarean rate at Holy Family is over 40%. It's the highest in the state. And I don't know, and they don't deal with the high risk population.
I'm just going to put a comment. The residency started in 1994. I want that slide actually right now because that line is went down, right?
Well, that's it. Is the family practice residents in this field, and they do a lot of the deliveries. But this is anyway.
The Holy Family is a private hospital.
Yeah.
Where the money is.
Yeah. Okay, and final one on maternal mortality, really bad. Okay, you see. I'll just make 2 points. Most of my research in the last couple of years has been on maternal mortality. I'm on the Massachusetts Maternal Mortality Review Committee. It's really been a focus of my work. And I just want to make a couple points about this before we go. One is that this one, most of the deaths are not in labor. The picture of people have of maternal mortality is from like Downton Abbey. Right? The woman is in labor, she gets a clamp dick, she dies while delivering the baby, right? That's true, that happens, but it's only about 1/3 of the deaths. 2/3 of the deaths happen either in pregnancy or postpartum. It's a public health problem. Secondly, it's going up in the United States. And all other industrialized countries, it's staying the same or getting lower. Massachusetts is doing well on this too, among other things. Massachusetts does really, really quite well on this. But that the disparities, the black-white disparities in maternal mortality are greater than the already high black-white disparities in infant mortality. In other words, it goes to this issue of we value kids more than we value mothers. And if we don't start stepping back and taking a bigger approach to this, we're going to have a real problem. The United States, compared to other countries that have a lot, at least 300,000 births, we're last in all of that. You say, but look, you have those high disparities. It must be a problem because of the disparities. Sorry, if you just use the white rate in the United States, we're still last. So we managed to have a problem of both disparities and system problems. And that's going to take a big effort. Okay, that's it. If you Google birth by the numbers, and again, do not Google animal porn. Trust me, okay? Just be clear on that, all right? If you do go to birth by the numbers, I'll have these slides posted in the next day or two. And there's a bunch of other stuff there. It's got a lot of useful information.
And we're also on Facebook and Twitter.
That's right, because I have no clue about these things, and God bless her, Christina is aware of all that. And there's no time for questions, but I'll be around. And I can only talk about this for another 6 or 7 hours.
Well, actually, there is time for questions.
Oh, good.
I'm sure people would like to ask some. Yes.
Yeah.
You know, BU had a wonderful nurse midwifery program. I believe it closed in 2006.
Yep.
And can you speak about that? Why we
Oh,
don't
I
have a
can.
midwifery program in Massachusetts at all?
We established the nurse midwifery program because of the disparities that were happening in Massachusetts. The problem that we had was simply that nurse midwifery programs shouldn't probably be in big private schools because it was just too expensive. People couldn't afford to do it, and so we weren't getting any applications. And so the schools that have had the most success, now if you look at nurse midwifery training in the United States, the schools that have had the most success have hybrid programs where people can come in without a nursing degree, they do a year of nursing, then they do 2 years of midwifery training. The people who were coming to us were generally not nurses to begin with, and wanted to have that sort of package program. There's a lot of nursing fighting that goes on around things, and we tried to ally with one of the nursing schools to have that year intensive. Prior to that, we couldn't do it. And so it wasn't because people didn't want it, we all wanted it. We just weren't getting any students. There's a program out in Springfield, it's thriving. It's cost a fraction of what we ended up costing. That's a real dilemma.
Where's the program?
Lay midwifery, I studied lay midwifery in Texas.
Yeah.
And it's very strong in Washington State and Vermont, and there's a couple of specific locations, but there you have the kind of the problem of integrating that model of care and the location where non-nurse midwives are allowed to practice with the medical system, and it's difficult.
Yeah, and they would have a seizure being termed lay midwives.
Yeah.
Certified professional midwives would be the term that they would, because they go through a fairly formal training program as well. It's a national certified.
What's the name of the program in Springfield?
It's at Bay State Hospital. Yeah. Others.
Is there a theory that's been posed to suggest why the maternal mortality is rose after the fact?
So there's a couple things that have worked. One is, some of that's a little bit of measurement. We're doing a better job of measuring it than we did in the past. But that shouldn't be much comfort. If I can get this one quickly. Because what that simply suggests, so the argument is we're just doing a better job of measuring it now. But think about that for a second. What that means is we sucked before, right? That it was up here sometime before, we weren't picking them up. Now we're picking them up. And so it might not be, one of the lessons in this is it's not increasing as fast as some people thought. But that's only because it was higher in the past. That's one of the issues. And the reason we fall further behind other countries is the other countries we're comparing to are also industrialized countries with really good data systems. And their rates have pretty much stayed the same as they improve the data and they're finding cases better. That's one piece. Another is, again, we're having more problems. We don't care about mothers that much. If a woman is between, this would be Massachusetts, between 133% and 200% of the poverty level, she's not pregnant, she's not getting insurance. She gets pregnant, they cover her. 60 days after she gives birth, she's off again. A third of the deaths are occurring in the period between 7 days and a year after the birth. But we throw them off. And because they've served their purpose, right? They've delivered us, hopefully, a healthy baby. So that's a piece of it. I've looked at, if you look at death rates, again, just a fun time. But if you look at overall women's death rates, one of the really intriguing things is, if you look at it by ages, for women less than 15, it's going down. For women between 50 and 80, it's been going down consistently. For women of reproductive age, it's been flat for the last 20 years. And so, the other point is, this is like a tip of an iceberg issue. This isn't a maternal mortality problem, it's a women's health problem. And we've had more problems with that. On the Maternal Mortality Review Committee, we get a lot of cases where it's social factors. You know, clinicians look at it and say, this isn't pregnancy related. And those of us who are on the committee, who are public health people, say, of course it is, but it's not, you're not going to solve it when she's coming in to have a baby. It needs to be solved much earlier than that because they bring life issues with them that haven't been attended to for a long time. And you can't resolve that very quickly. Okay. Do I have to? Okay, my wife, oh no.
No, I was just going to say that the issue of not accepting midwives in the second or the last quarter of the 19th century and well beyond, it's reflective of the general conflict between men and women and in all sorts of workplaces.
That's true. You're not talking about us, right? We're talking about men and women generally in the 1800s.
For instance, the first Irishman, you were talking about the Irish relying on physicians. The first Irish mayor, Tom Green of Lawrence, and I'm going to mangle this quote, but he said, the young ladies of Lawrence, of whom there are a surplus, should go out west and make some young man happy. So there was a great deal of that in all the areas.
Thanks, if you like.
Question going back to your very early, the early slides talking about...
About 150 slides ago.
So, and going back to the 1918, 1919, okay, I was been looking at some of that data for a particular group, and one of the things that kind of jumped out to me was that while the peak, the influenza death peak seemed to be in late 1918, I don't think too much disagreement on that, that in 1919, that there was a peak in stillbirths and young infants under 30, those that didn't live 30 days, not even 30 days, that was higher than any of those years, to the point where if you said the influenza, the deaths from influenza were really much higher than people are thinking about, except a lot of them came in 1919 in a way that people didn't think about. But I was only looking at one section, so I'm just looking at your comment. If you think that, yeah, that's probably true or not true, or...
I mean, you have a combination. Obviously, if we're talking about stillbirths, we're talking about something that's going to happen for many months after a particular infection, so that could carry it over. You also have really bad data keeping back then, and so some of the irregularity, it makes it look, if you look at the old records carefully, it looks like January is like a death month. And it isn't. It's just the bad reporting of deaths that might have occurred in the month before, which pushes it into the next year's rate scores. So
I think this is not
bad.
pushing in. I mean, we can talk about it a little more afterwards.
Yeah.
I guess my question is, what are these women dying of who are dying within 3 months after the birth of their children?
Talk about now?
Yeah, we're talking about now.
This is a little bonus thing. That's get you going. Okay, so the leading causes of death are hemorrhage, postpartum hemorrhage, right? Eclampsia, which is but the interesting thing is, if you look over the last few years, those are going down because those are clinical things, and there's been a huge clinical effort to try to improve care around that. national effort that's been underway for the last few years. What's going up are cases, a lot of them related to cardiomyopathy, cardiac disease as a whole is increasing a whole lot. Some of this is, and then the other piece that's an element in all of this is the same thing that's happened with so many other discussions, opioid issues, substance use issues. On the review committee, I don't get the clinical, I'm not a clinician, I don't get the clinical cases. I get the social cases and I get a lot of those kinds of cases. And that's what I mean by, so on a maternal mortality review committee, you get a case in and you review it and you try to make a determination, was this pregnancy related or not, and then was this preventable or not. And both end up being tough arguments, but on the preventable one, we always end up having this argument about, well, if you had like a really functional social system who identified this woman's risks earlier and got her care before she got pregnant, then this is preventable with all of that. For the clinicians who are maternal fetal medicine specialists, they look and say, I could have prevented this. And of course, the answer is yes, you couldn't have prevented it, but we could have prevented it with a more functional system. Or the other side of it is, we have mental health issues that have become a bigger component, and a lot of that manifests itself after the woman's. So a combination of the two, and this is small numbers still. But you have people who have substance use issues. They come through, they get sober during their pregnancy, either alcohol or other substances. They get sober during their pregnancy. This is going to be the birth that turns everything around. They go through that, they do a magnificent job. There'll be a lot of supports if they get into a system then. There'll be a lot of supports for that. They have the baby. DCF still comes in and takes the baby away in most cases because the rest of their lives are still screwed up, right? They probably have 3 kids who are in foster care and all those different things. Once that baby's taken away, it crushes them. It's just...
And all the supports are gone.
For the most part, they're gone. I was at a regional meeting, a New England meeting of mortality review committees, and I asked the people from the other states, is there a system here for us? Is there a system for women in those situations? And because again, there's not financing for all of it. And that disparity I said between what the eligibility for Medicaid coverage when you're pregnant and when you're not, 133% to 200% is the national average. Right? So for a woman in a family, if they make more than 133% of the poverty level, then they don't qualify. Again, she's pregnant, it goes up to 200. In some cases, some states, in DC, it's like 370%. Right? In Texas, it's 200% which is pregnant. It's 18% which is not. So they're virtually all going to be thrown off the day after, the minute they hit that period of time. And so then they're out of the system. Then you lose track of them, and something happens, and the only time you see them is when they get recruited in mortality.
Yeah.
Do organizations like Planned Parenthood have a position on midwifery?
They may. Certainly midwives do more than deliver babies, right? They provide women's health care, and they do a lot of reproductive health care. And so, sure, they may well work with us in those settings.
Just some of those capturing the pregnancy-related, the maternal mortality is because the death certificates, they added a box to it that said pregnancy-related. So more people, more docs are checking that off, where it was just omitted because somebody died of, a heart condition or, another infection. So they weren't capturing it, but now it's being captured more.
You're in my sweet spot. We wrote the article about that. And what you have is, it was, again, good intentions. They were worried they weren't capturing women who died during their pregnancy. In a normal review, why would the person doing a death certificate realize she had been pregnant or recently pregnant? So they added this box. When they added the box, it took care of that. I mean, there's a great study that finds that 2 things. One, that about of the pregnancy-related deaths they identified, there was 14% were not pregnant. And it's because of the box was there. I can go into that a lot more if I can. But the other thing is, they also found like 7% more deaths that they wouldn't have found without the box. This is hard, this is really different. Again, it was all goodwill, all good intentions. Really hard to capture this. Okay? All of which, let me just end the point, it was really kind of cool. And they can play a really important role in all of this. And we rely on them in the United States far less than virtually every other industrialized country to our detriment. And so, and this campaign had nothing to do with their outcomes. It had everything to do with interprofessional rivalry. And the lack of any sense of midwifery alliance. I looked through all those records to see, did Minnie Ream ever take a vacation? She's delivering 300 babies a year. Did she ever take a vacation? And my goal was to see if she took a vacation, did someone else step in, right? And I looked through 2 things. Minnie Ream never took a freaking vacation. And really, it was like never more than 3 or 4 days when she was delivering. But also, there was no way I could ever find replacement. That one midwife would step in for another midwife through here. There was no common sense of a profession. Whereas among physicians at the time, that was a huge help. And if you want to succeed in a world of professions, you got to see yourselves being in a profession.
Thank you.